All right. So we're going to get things started tonight with a few introductions, and then we'll dive into our discussion on risk factors for breast cancer, what you can do to reduce your risk, and ways to detect, diagnose, and treat breast cancer. So once again, please feel free to ask your questions, and let's jump in. So tonight we're joined by two talented breast surgeons with Ascension St. Agnes, Dr. Kristen Fernandez, who is the surgical director of the Ascension St. Agnes Breast Center. Dr. Fernandez is a board-certified general surgeon who specializes in the treatment of breast cancer as well as benign breast disease. Dr. Fernandez has extensive experience with state-of-the-art treatment options, including breast-conserving surgery, accelerated partial breast radiation, and nipple-sparing mastectomy. At the Breast Center, Dr. Fernandez enjoys helping women understand the treatment options available to them and works collaboratively with each patient to develop an individualized treatment plan. She's an avid proponent of regular mammograms for detecting cancer when it is early and easier to treat. And Dr. Fernandez is joined by Dr. Nolene Rajarajan, a fellowship-trained surgeon who specializes exclusively in breast surgery and breast disease. She works closely with the multidisciplinary care team at Ascension St. Agnes to provide exemplary care for patients with all breast-related diseases, including breast cancer, high-risk breast lesions, and benign disease. She is skilled in all aspects of breast surgery, including mastectomy, partial mastectomy or lumpectomy, and axillary surgery, as well as specialized techniques including nipple-sparing mastectomy, oncoplastic surgery, and hidden scar surgery. And now I'd like to turn things over to Dr. Fernandez to give us a little bit more detail on the Breast Center at St. Agnes and get us started with tonight's presentation. Welcome, Dr. Fernandez.
Thank you. And thank you so much for joining us, everyone. We're really glad you could take some time out of your Wednesday evening to spend some time with us. And we hope you learn a lot about this. And please, if you have questions, please ask them in the Q&A box, like Kelly said, and we will try and get to every question. So the Ascension St. Agnes Breast Center has two locations. Our main location that most of you have known about, we've been here for many, many years, is right on the hospital campus on Wilkins Avenue. And we have a new location in Columbia where we've been for about the last 2 years. We're very fortunate in that both locations have similar things available for patients. So Dr. Rajarajan will talk a little more about breast imaging, but we're very fortunate to have a breast imaging center right next to us, Seton Imaging, at both locations, where we can do screening mammograms, diagnostic mammograms, breast biopsies, breast MRIs. The breast surgeons have offices at both locations, and our medical oncologists even see patients at both locations. So the Columbia office is, you can see the address on your screen, at Alexander Bell Drive, which is Snowden River and 175 in that location of Columbia. So Dr. Rajarajan is kind of doing all the work tonight. She's going to do the presentation, and then I'll be available when it's time to answer questions. I'll chime in as well. So I will hand the floor over to her, and hope you enjoy the presentation.
Okay, so I'm Dr. Rajarajan. Thank you again for joining us today. I'm going to just kind of go over what we're going to be talking about today. So we're going to talk about some of the risk factors that there are for breast cancer, what you can do to reduce your risk of breast cancer, how we detect breast cancer, diagnose it, and a little bit about how we treat it as well. Ask whatever questions you have. We always say there are no silly questions. So just whatever you have, just ask us. We're happy to answer anything for you. Okay, so let's get started. Breast cancer, unfortunately, is one of the most common cancers that we find in women. About 30% of all cancers found in women are going to be of the breast. Now, that means that 1 out of 8 women are going to develop breast cancer in their lifetime. So there is a good chance that you will know someone who will be affected by breast cancer, whether that be a friend or a family member or a colleague. Now, in order to know a little bit about breast cancer, it's important to know a bit about the breast. And the breast itself is made up of our breast tissue, and then that's usually surrounded by some fat. So the breast tissue itself is made up of lobules. They make the milk, and then we have ducts, milk ducts, that take the milk out through the nipple. Then we have some supportive tissue that holds everything in place. Now, the lobules and the ducts are where we often find breast cancer will occur. So often when people get breast cancer, it will be called either an invasive lobular cancer or an invasive ductal cancer. And that just means those are the cells where the cancer is growing. Okay. So people ask, well, why does cancer occur? How did this happen? So usually cancer occurs when one of the normal cells, as we said, one of the normal lobule cells or one of the normal ductal cells undergoes a genetic mutation. So something happens, and instead of becoming a normal cell, it becomes abnormal. And then it starts to grow uncontrollably. Now, usually the body would figure this out and get rid of the cell. However, it does not manage to figure this out, and the cell then grows uncontrollably. So it continues to grow, where it can then invade local tissue, and then it can get the ability to spread to other organs. Now, no one can predict who is going to develop breast cancer, but there are certain factors that can increase the risk of breast cancer developing, and that's what we're going to talk about now. Okay? It's important to know that breast cancer caught at an early stage is very treatable and curable. And that's why you'll often find breast surgeons and many doctors talking about why we want people to go ahead and get a mammogram. It's because mammograms can detect breast cancer at a very early stage when it's very treatable. So let's talk about some of the factors that can increase your risk of developing breast cancer. So we can often put them in two components. One can be things that we can't change. We call those non-modifiable, and things that we might be able to do something about, and those are modifiable. So let's talk about some of the non-modifiable things, the things that we can't unfortunately do anything about. So the first thing is gender. As we know, we talked about 1 out of 8 women will develop breast cancer during their lifetime. However, this doesn't mean that it's only women that develop breast cancer. There are men with breast cancer, and often they come to us a lot later because they don't realize they can get breast cancer. So certainly, if you have a brother or a husband or a son, and you know that you have a very strong family, have breast cancer in the family, and they notice a lump in their breast, certainly they should be aware of that, and that if they feel something, they shouldn't hesitate to come and see us as well. Okay, but it is usually a diagnosis of women. So only about 1% of breast cancers happen in men. Now, unfortunately, as we get older, the risk of breast cancer increases. So age is very important. And this is a little chart. It's a little bit older, but it kind of tells us how often these associated to the age, you can get breast cancer. So you can see in your 20s, it's very unlikely that you're going to be diagnosed with breast cancer. It's like 0.1%, so very rare. But as you get older, you can see that that risk increases, okay? And it's often the same case with many cancers, unfortunately. As you get older, your risk of cancer increases. Sorry, my light just went off. There we go. All right. So as you can see, from the age of 40, the risk of breast cancer does increase. And that's why we like to start doing mammograms at that age. And also it's to do with breast density. And we're going to talk about that in a little bit. Okay, the next thing is family history. So certainly having family members with breast cancer does increase your risk of breast cancer. We know that 5 to 10% of breast cancers can be due to genetic mutations. So that means that you may have something in your DNA that is abnormal that is increasing your risk of breast cancer. Now, only, like I said, 5 to 10% of that is due to the genes. However, 20% of breast cancers can run in families, and we don't always find a gene for that. So if you do have a number of family members with breast cancer, that includes mothers, sisters, aunts, specifically, that have breast cancer, there's an increased risk that you might get breast cancer, and it's worth finding a breast surgeon to talk to about to see if you would benefit from additional screening. Now, the most common mutations of breast cancer are the BRCA1 and BRCA2, and you may have heard of that. However, there have been identified a number of genetic abnormalities that can lead to increased risk of breast cancer. And some of them can increase your risk by a little and others a lot. So if you have a number of family members and you want to get genetic testing, we can provide that service in our clinic. You just need to give us a call and we can arrange for you to meet with Deirdre, who is our PA, who specializes in the high risk breast clinic and genetics. And she can talk to you about the risks and benefits of undergoing genetic testing and what to expect. So you may be asking the question, well, should I get tested to see if I have an abnormal gene? So the people who should be thinking about this are people who have a history of breast cancer. So a lot of breast cancers, the insurance companies will cover you to get testing. Now, sometimes, unfortunately, insurance companies don't always cover that, and we will let you know if that's an issue. But if you would like to undergo genetic testing, you can let us know and we can let you know if they will cover you. Now, family members who develop breast cancer before the age of 50, so we call these premenopausal breast cancers, those patients who have family members that get that kind of cancer should consider getting genetic testing. Family members who have family with close family relatives with ovarian cancer. We know that ovarian cancer is often very strongly related to genetics. So if you have ovarian cancer as well as pancreatic cancer, those cancers can often run in families. Important to think about genetic testing. Other cancers that can be linked together, so often you might not just have breast cancer. Things like BRCA can also affect the pancreas, the prostate, and the ovaries as well. So certainly if you have a number of family members with those kind of combination of cancers, you may want to think about getting tested. Now, if you have a family member, mother or aunt who had bilateral breast cancer, now it's not, we know that 1 in 8 women are going to get breast cancer, but if you have one on each side, that just means that you're at higher risk that maybe there's something wrong in the genes. You might want to think about it then. And then again, triple negative breast cancer is another more rare type of breast cancer. And certainly if you have that, you may want to get genetic testing. We already talked about it's rare to get breast cancer in men. So if a man has breast cancer, we do like to do genetic testing on them to make sure that there is no genetic abnormalities. And that way we can also then test other family members. Ashkenazi Jewish background also has an increased risk of having a genetic abnormality. So if you have that in your background, you want to think about getting genetic testing. It's always better if a family member who has breast cancer tests rather than yourself. And usually what we would do is if they test positive, then it's easier for us to test and just see if you don't have that gene. However, if they don't want to get tested, that is completely up to them. Some people just don't want to know. And if that's the case, you can always come let us know, and then we can see if we can get you genetically tested. Okay. Now, in the past, when they did genetic testing, this is usually pre-2014, when they did genetic testing, they only did BRCA1 and 2. And now we test for anywhere between 70 to 90 genes. So if you had your testing before 2014 and it was negative, you may want to come back and get additional testing. Now, the testing is often done as a saliva sample, so nothing to eat or drink for about 30 minutes beforehand, and they swab your mouth. Sometimes they will also require a blood test. Okay. Why would you want to get genetic testing? Well, knowledge is power. Knowing kind of if you have an increased risk, it allows us to make a better idea what your risk might be. And then it can help us to make a plan to prevent breast cancer or catch it as early as possible. As we said, catching it earlier increases the risk that we can cure it. We'll also talk about things you can do to lower your risk, and we're going to do that. That's what we're going to be doing today. And then sometimes if you do have an increased risk or you have family members that had breast cancer early, you can get enhanced screening. And that may mean getting mammograms early or getting additional imaging with MRI imaging. And we're going to talk about that soon. All right. There are a number of different results you might get, and I'm just going to run through this quickly. They could be positive, in which case we'll get you in touch with a genetic counselor so that you can understand what those risks are, and then we'll make a plan for you. You will often be followed in our clinic. It may be negative. Now, negative can sometimes, be a two-edged sword. If we know that your family is positive for breast cancer, so if you have a number of family members with BRCA and you test negative for BRCA, then you don't have that additional risk. So then you can, you don't have to worry about all that additional screening. However, if you had a family member that tested negative and now you're negative, that doesn't really help us. So the plan will be is we'll continue to monitor you closely just in case there's something that we still haven't learned about, or there's something something else that might be going on. Some people get a test that says VUS, which means variant of unknown significance. What that basically means is it's a little bit different from normal, but it's not been shown to be a problem. So often once they get more people who have had that and they find they've not developed cancer, they'll usually send you a letter to let you know that there's nothing to worry about. So 95% of people will get a letter within like 5 to 10 years saying, don't worry, this is nothing to worry about, okay? Sometimes when you have an abnormality, you need two abnormal genes because you get one gene from your mother and one from your father. Sometimes you just need one, other times you need two. Now, that's not a problem for you if you need two. However, it might come into effect if you're going to have children and you end up having children with someone who also is a carrier. That might then lead to your children getting an abnormal two genes, okay? Now, some people feel that they're not going to get breast cancer because they don't have anyone in their family with breast cancer, and that is false. Up to 85% of women who develop breast cancer do not have a family history of breast cancer. So don't believe just because you don't have anyone in your family that has breast cancer that you're not going to develop breast cancer. Okay, so next, we talked about gender, age, family history. Next is breast density. And there's a good chance that many of you have heard about breast density from when you got your mammograms. Often when you get your mammogram, if you have dense breasts, you'll get a letter saying, hey, you have dense breasts. And often you don't know really what to do with that. But it's just letting you know that about 50% of women do have dense breasts. So 50% have kind of a variability of dense breasts, and then 10% of women may find that they're told that they have extremely dense breasts. The problem with dense breasts is that it makes it a little bit harder to look at the mammogram. And I always say to people, it's a bit like looking in a forest. If you're looking for a baby bear in a forest and it's a dense forest, it's really tough to see that bear. There's lots of trees, very difficult to see. Same with dense breasts. Now, if there's 3 trees and it's a fatty breast, it's very easy to see that baby bear. Likewise, very easy to see the cancer in fatty breasts. So if you do have dense breasts, or you've been told you have dense breasts, you have a normal mammogram, but you think you feel something or you're worried about something, don't be scared to go to your doctor and say, hey, I really think I feel something, even though my mammogram was normal. And usually we will do some additional tests to make sure there's nothing else there. Okay, so dense breasts do increase the risk of developing breast cancer. It also makes it harder to see. The good news is that breast density often will decrease as you get older. So as you get older, you have children, and if you gain weight as well, often the breast density may decrease, making it easier to read those mammograms. Okay, next is female hormones. So we know that our female hormones play a crucial role in developing breast cancer. And one of the reasons we found this out was they were finding out that a lot of nuns were developing breast cancer. Now, the reason for that is that they have a longer period of hormones because they do not have children. And during that time when you have children and breastfeed, you're not undergoing those normal cycles. So women who have their periods that start early, so less than 12, a late menopause greater than 55, those are increased risks of breast cancer. Likewise, breastfeeding decreases your risk of breast cancer. So, high-risk breast lesions. So what are high-risk breast lesions? So often when people go for their mammograms, most of the time, thank goodness, your mammogram is normal and you don't have to do anything else. But sometimes you get called back for additional mammograms, and sometimes you might have to undergo a biopsy. Now, if you undergo a biopsy and you're told it's benign, that's great news. Usually you might not even need to do anything more. Unfortunately, if you get told it's breast cancer, we're going to talk about what you do then. But sometimes it comes back as abnormal or atypical. So atypical disease is where the cells are starting to look abnormal. They're not cancerous, but they're starting to show signs that they may be going down that pathway. So often you'll find the word atypical in there. So atypical ductal hyperplasia, that basically means the duct cells are looking a bit abnormal. Hyperplasia just means there's a lot of them. There's also lobular carcinoma in situ. That's not actually a cancer, although it has the word carcinoma in there. That was named a long time ago, and no one has changed that. So if you have anything that says atypical in it or lobular carcinoma in situ, we consider these high-risk lesions. This just means that your risk of breast cancer is increased. So you should be followed by a breast surgeon if you've been told that you have any of these, even if it was in the past. So often for a lot of these women, the atypical ductal hyperplasia may require surgery, but some of them just need following. But those are high-risk lesions. You should be followed by a breast surgeon if you've ever been told you have any of those. Last one we're going to talk about, non-modifiable, is radiation. And what do we mean by radiation? This is a very specific type of radiation that is given to younger women, and it's called mantle radiation. And it was given for Hodgkin's lymphoma and non-Hodgkin's lymphoma. And it's basically young women who develop this lymphoma. They treat it with an X-ray type treatment, which is radiation that is given to the chest. Unfortunately, it also hit the breasts, and often this is during the time when they're developing. So these women have an increased risk of breast cancer. So after the age of 40, it doesn't increase. The reason being it was the developing breast, especially women treated in their teens or early years then. So if you had mantle radiation for lymphoma, it is important that you are followed up in a breast clinic. And usually they say that risk starts after about 8 years. So 8 years after that, you really should be followed on a regular basis at the breast clinic. Okay. So we often get asked questions about, what about race? Does race change whether we have, whether we get breast cancer or not? We know that it's a complex relationship with race. So we know that breast cancer is the highest in Caucasian women. Unfortunately, though, Black women are more likely to be diagnosed at a younger age and at a later stage. Okay, and we don't know whether that's something to do with genetics, whether that's a socio-economic issue to do with healthcare, access, income. Also, there's many other things, the age that people have their children, the age they have their periods, their breast density, all those things may play a part. So it makes it very difficult to untangle. So we talked about all the non-modifiable risks. So unfortunately, you can't do anything about any of those. However, there are some things that you can do to decrease your risk of breast cancer, and it's all to do with diet and lifestyle. Now, I say to women, you can do everything right, and sometimes you can get breast cancer. You can do everything wrong and never get breast cancer. However, every little thing you do does slightly decrease your risk, or if you have breast cancer, it can decrease the risk of breast cancer coming back. So let's talk about those things. The first thing is alcohol. We know that drinking alcohol increases your risk of breast cancer. 1 drink up to 10% compared to a non-drinker, 2 drinks, 20%. So certainly for a lot of my high-risk patients, I say to them, if you can stop drinking alcohol, it's always worth doing it. Likewise, being overweight increases your risk of breast cancer. The reason being is that our fat can often be turned into estrogens, and those estrogens do increase the risk of breast cancer. So you want to try and get to an ideal weight as possible. We know that some foods can increase your risk of breast cancer. These include processed foods and red meats. Diets high in vegetables and fruits have been shown to decrease your risk of breast cancer. So having a very healthy diet, and some would say plant-based, does decrease your risk of breast cancer. I understand that's pretty tough. I don't do it myself, but every little thing that you can do, if you want to do it, does count. Smoking does increase your risk of breast cancer. And it's pretty terrible for everything. So ideally, you want to try and quit smoking. And certainly there's a lot of kind of help out there from your primary care and other sources to try and help people decrease smoking. Physical activity, really important, does decrease your risk of breast cancer. Having about 150 to 300 minutes of moderate activity a week. Okay, and that you can space that out per day, however you want to do, but exercising on a regular basis decreases your risk of breast cancer. Okay, so other things that you can do would be to do with female hormones. We know that HRT, or hormone replacement therapy, which can be given after you go through the menopause, can increase your risk of breast cancer. However, stopping it does usually tend to put your risk back down to normal. Okay, so we always say to people, you can take HRT if you need to take it, take the lowest dose and stop the earliest time you can. Okay. Estrogen-only replacement therapy has not been shown to increase your risk of breast cancer. However, if you do develop a type of breast cancer that's sensitive to estrogens, we will unfortunately need to stop that. Birth control is also felt to increase your risk of breast cancer slightly. That risk returns to normal after you stop it. The shots that you can get, the Depo-Provera shots, there's been no conclusive evidence to show that increases the risk of breast cancer. Same with IUDs. There's no conclusive evidence that those also increase the risk. Now, unfortunately, the time and when you have your children can affect if you develop increased risk of breast cancer. So we mentioned about nuns, we know not having children increases your risk of breast cancer. Likewise, having children later in life also increases your risk of breast cancer. So over the age of 30, having your children younger in life does decrease the risk of breast cancer. Okay, so there's often a myth going that if I lead a healthy lifestyle, I'm not going to get breast cancer. If I do everything right and I don't have a family history of breast cancer, I'm not going to get breast cancer. And unfortunately, that's not correct. As we talked about, it just takes one cell to make a mistake, and your body, it just kind of slips through the defenses and it doesn't get picked up. And that's why it's so important to undergo mammograms, because it can pick those cancers up at a very early stage before anyone can feel it or before anybody knows anything is wrong. So there are a lot of kind of misconceptions about things that may increase your breast cancer, risk of breast cancer, but have not been proven to increase the risk of breast cancer. So underwired bras, having a miscarriage, having an abortion, breast implants, caffeine, deodorants, cell phones, all those things have not been shown to increase your risk of breast cancer. Now, sugar in itself has not been shown to increase breast cancer. However, sometimes it can cause some inflammatory effects that may be shown to increase the risk of breast cancer. So it's a little bit kind of shady there, but the others have not been shown to increase your risk of breast cancer. Okay, so how do I know if I have an increased risk? Do I need to do something? Do I need to see a doctor? So it's very important, if you have a strong family history of breast cancer or ovarian cancer, you should probably see a doctor to decide if you have an increased risk and may benefit from additional screening. If you have a history of radiation, if you've had a history of this high-risk breast disease, so anything that said it was atypical, or you had a history of this lobular carcinoma in situ, or a history of breast cancer, you have a slightly higher risk of breast cancer risk compared to the general population. Do you have dense breasts? Now, this in itself doesn't necessarily mean you're at increased risk, but if you've ticked a few of those boxes, you may be at increased risk. So if you have dense breasts, you've had a biopsy, you had your children later in life, and you have a sister with breast cancer, there's a risk that you might be high risk. Also, if you've had a high exposure to female hormones, so say you've taken HRT for like 20 years, that might increase your risk of breast cancer. Now, often what we will do is we'll plug your details into a risk calculator, and certainly there are a lot of them available on the internet that you can use. So you can look at the high-risk breast calculators. We often use either the Gale model or the Tyrer-Cuzick. We plug those numbers in and we see what your risk is. Usually a lifetime risk of greater than 20% means that you would benefit from high-risk screening, but often if you have an elevated that's somewhere close to that, we will probably keep an eye on you as well. So if you're worried, you can always give us a call. We'll be happy to see you. We do run a high-risk clinic that is run by Deirdre, our PA, who specializes in high-risk breast disease. Okay, so we're just going to go over everything. What can you do? You can maintain a healthy weight. You can exercise regularly. You can stop smoking. You can eat a healthy diet. You can get your screening regularly. If you have a strong family history, you can make sure that you start your mammograms early if you need to. You want to avoid HRT if you can, avoid alcohol, eat a healthy diet. There are medications we can give you to reduce your risk of breast cancer. But these tablets can make you feel like you're going through the menopause. But if you have a high risk, it's certainly something worth asking your doctor about. You want to get your mammograms regularly. You want to examine your breasts regularly. And for women who have a very high risk of breast cancer, so usually those with genetic diseases that really increase their risk, they can undergo prophylactic surgery to remove their breasts to decrease that risk. So now we're going to open the floor and just answer some questions.
Okay. This is a great question. So someone said, my mom had breast cancer at age 45. Should I be doing mammograms earlier than age 40? So definitely. So Dr. Radarajan talked about things that might increase your risk. And this is definitely one of them. So the current recommendations are that you start your screening mammogram either at age 40 or 10 years younger than your youngest first-degree relative. So if your mom had breast cancer at 45, you would certainly start screening mammograms more like around age 35. And then also you would probably qualify for getting advanced screening, so something like a breast MRI. And whenever we do advanced screening or high risk screening, the woman will get her mammogram and then 6 months later get the MRI. And then 6 months later, it's time for a mammogram again. So instead of getting one screening study a year, just a mammogram, you're getting two and they're spread out by 6 months. So it's just a way to watch your breasts a little closer. So excellent question. We do have high risk MRI screening available at Seton Imaging at Ascension St. Agnes. So the next question, I'm concerned that I have breast cancer on two sides of my family. Should I see a breast surgeon or talk to my OBGYN first? So OBGYNs are a great resource. They know a lot about breast cancer. They know a lot about breast health. I would certainly recommend starting with them if they're available and they are comfortable discussing that with you. Many of our OBGYNs at St. Agnes, just because Dr. Radarajan and I will do educational things for them, or they'll, text us, email us, ask us questions so that they can give their patients the best guidance. So our OBGYNs are pretty on top of breast health. I think that that question, so you have breast cancer on two sides of your family. So if your grandmother on your mom's side had breast cancer at 82, and your grandmother on your dad's side had breast cancer at 84, and that's your only family history, remember, Dr. Rajarajan said the two biggest risk factors for getting breast cancer are being a woman and getting older. And if you're fortunate enough to live into your 80s, 1 out of every 8 women who lives into her 80s will get breast cancer. So that type of a family history isn't as alarming as if you have a first cousin and an aunt on one side who had breast cancer at 30, 35, 40, and maybe on the other side, 2 aunts and a second cousin who had it premenopausal. So yes, having it on both sides can be concerning, but it kind of depends on the age that you had it. So you want to answer this one, Dr. Rajarajan? If a woman has dense breasts, is MRI better at detecting cancer than a traditional mammogram? That's sort of a...
So
Yes,
the
no.
answer is yes, in a certain extent. And we're going to talk about this. So the problems with MRIs is, and we're going to go into MRI a little bit later. So we'll probably
Yeah,
go
maybe.
through that.
Yeah, maybe we should. So that's a good point. She's got a good MRI discussion on her slide. So if we don't answer that, put it back on the next time, or like just copy and paste it back in, and we'll be sure that we cover it. Can you repeat again why an increase in breast cancer is a concern for women without children? I was so this was I had a really great talk. This is probably about 10 years ago that someone at one of our national conferences said that, talked about this. So the way she described it, and it kind of helped me. So Dr. Rajan talked about, our cells divide all the time. Our cells are dividing. Sometimes the cell makes a little mistake. The body realizes it and sends other cells to kill it off so it doesn't become cancer. So think of the final maturing of the breast is to be pregnant and breastfeed a baby. Like that's technically what the breasts are supposed to do, right? So when we're in our teens and our 20s, our cells divide, and occasionally there's an abnormal cell, but not as frequently. We're young, our cells are young, we're not kind of doing as many, they're not doing as many wrong things. When you hit into your 30s and 40s, the cells are older, they're a little more irregular. So whenever you get pregnant, the way that the body matures the breast is you get a big spike in your hormones, a big spike in estrogen, a big spike in progesterone during the pregnancy. So the way it was explained at this conference was when your breasts are older, in their 30s or early 40s, they have more irregular cells, and they're getting all this hormone exposure. And therefore, those irregular cells get stimulated and can grow more irregularly and faster. Whereas if you're in your 20s or your teens, your cells are a little more normal. So that pregnancy rush of hormones doesn't affect them as negatively. So I thought that was a really good explanation. What do you have any other input to that, Dr. Rajarajan?
No, that's kind of what I learned,
Yeah.
it was also similar, yeah.
So I thought that, was
So
a
yeah,
good
it's
way to look.
nothing that you're doing.
No.
Unfortunately, it's just one of those things. It's not saying that it's a bad lifestyle choice. I don't have children.
And I have my first child over age 30. So there's lots of
so
us
you
running
don't.
around like that. And fortunately, Dr. Rajarajan and I have not had breast cancer. So not everyone who has breast cancer either doesn't have children or had them later in life. That's not a thing. We have plenty of patients who get breast cancer even though they had children young. But if you have a lot of these risk factors, you don't have children, you have a family history, you started your period really young and went through menopause late, like all those things factored together, you might need extra screening. Does the COVID shot affect mammogram results? You want to get that one, Dr. Raj?
So it doesn't per se affect the mammogram itself. However, often what we found was when people got the mammograms, their lymph nodes would swell up. And the lymph nodes are just reacting to the injection. So they're reacting to the injection that you get. However, breast cancer can also present as swollen lymph nodes. So it was causing a lot of issues about whether this is the cause. Is it something else going on? So often what they may say, and I don't know if they're still saying that because now they kind of have a better idea of what's going on, but if you've just had the COVID shot, and it's probably your first one, maybe it doesn't happen as much with kind of the subsequent boosters. If you get a lot of kind of swelling in your armpits, probably not worth getting your mammogram at that time. But now if you let them know, they'll kind of keep an eye on it.
Yeah, we usually recommend that if you're getting your screening mammogram, so nothing's wrong, you don't feel anything, there's no nipple discharge, your breasts look and feel completely normal, it's just time for your mammogram, you should probably try and get that. Don't get that a week or two after the COVID vaccine because your lymph nodes might be swollen. Try and wait 4, 5, 6 weeks after your vaccine. Try and time it that way. So again, the vaccine doesn't cause breast cancer. It doesn't, nothing like that. It just can show swollen lymph nodes, and swollen lymph nodes can also be a sign of breast cancer that has spread. So it was just confusing sometimes with the mammogram. Does the presence of a fibroadenoma count as an atypical condition that increases breast cancer risk? It does not. As long as your fibroadenoma is just a plain old fibroadenoma. So if you get a needle biopsy and the diagnosis is fibroadenoma, it really doesn't increase your breast cancer risk the same way that atypical cells do. This is there is no answer for this, but I'm going to read it and I'm going to do my best to try and talk through it. So why are so many young Black women in their 30s getting cancer? We really do not know. And that's something that breast cancer researchers and specialists, not only are younger Black women getting cancer, but even when you compare younger Black women to younger white women, the cancers don't seem to respond the same to the therapies that we have. So we know that more young Black women die from their breast cancer compared to young white women, even though cancers present the same types and the treatments are given the same, there's still a higher death rate. Some of that, and Dr. Rajarajan alluded to it, some of it is disparities in access to healthcare. So in some parts of the country, mammograms aren't available as readily. In certain areas of the country that have a lot of lower income Black women living there. So that does factor in. But when you look at people of the same economic status and the same access to care, and they're getting the same, health screenings, there is still a higher death rate. And there is no known reason. This person says, my mother was a breast cancer survivor for more than 25 years. However, my sister was diagnosed with triple negative breast cancer and only survived 2 years with treatment. I am so sorry to hear that about you. My sister tested negative for the BRCA genes. This patient says, I've considered genetic testing because I do have a couple of the risk factors. Is it recommended that I get genetic testing, or should I just continue with routine screening because my sister tested negative? So there's a couple of parts to that. You should not be getting routine screening. If you have a sister, and I'm assuming your sister was young, especially if your sister was under 50, but really if your sister with triple negative breast cancer and your mother with breast cancer, you probably have, when we do the risk testing, you probably have a greater than 20% lifetime risk of breast cancer. So you should be getting screening mammogram and screening MRI at 6-month intervals. As far as getting genetic testing, there's really no, your sister didn't have a gene mutation. If your mother is still alive, she can be tested. I don't know, Dr. Raj, I don't know
Yeah,
if
I mean,
you
it also
disagree,
depends
but
on when she was tested and what they tested for,
that's
because
yeah.
some places only test for a couple of genes, and if it's BRCA1 and BRCA2, but there are lots of other genes now that we look for. So sometimes we just have to see you and have a better idea of what's going on. Usually with a mother and sister with breast cancer, they're probably going to be happy to retest you for the rest of the
Yeah.
other gene panel.
Yeah. And if you test negative, and that's the problem.
Mm.
If you test positive, that's meaningful. We know what that means. We know, okay, you have a gene mutation. We can kind of talk about that and guide you on that. If you test negative, we don't know if that's a true negative. In other words, maybe if your sister were still alive and she got tested now, if your sister was tested 10 years ago, there's different genes that we know about now. So, maybe your sister, had a mutation. It's just that when she was tested, we didn't know about that mutation. So you getting tested wouldn't be a bad thing, but you would need to be tested by somebody who understood it, like a breast surgeon, like a breast oncologist, like a high risk, like Deidre, our PA, who covers our high risk clinic. You need to be tested by somebody with that knowledge.
Mm-hmm. And I think no matter what, you would probably get followed in a high risk breast clinic.
Right.
So
Even if your testing's negative, then you should really see someone once a year at a high risk breast clinic, and then see your gynecologist once a year as well. We'll answer a couple more of these, and then I'm gonna let Dr. Rajarajan continue on with her talk. Are cysts more likely in dense breasts than fatty breasts, and when should you be concerned about cysts that continue to show as benign on mammograms? Cysts are a premenopausal woman's issue usually. So cysts are usually stimulated by hormones. So if you're still cycling, you're still having your menstrual cycles, then your cysts will get a little bit bigger right before your cycle, and then they'll get a little bit smaller. If the radiologists are seeing the cysts on your mammogram, they're not looking irregular, they are looking smooth bordered. Sometimes they'll do an ultrasound to confirm it. You should not worry about that. Cysts are easier to see in fatty breasts, but more dense fibrocystic tissue probably has more potential to develop cysts, but cysts can happen in, dense breasts and in breasts that are just partially dense. If you have swelling under your armpit, is it a sign of breast cancer? Sometimes. But other things can cause swelling under your armpit. Women can have what's called accessory breast tissue. So just extra breast tissue that sits in the underarm area, and that can look like a swelling. So if it's new swelling, particularly if it feels hard, you should absolutely get that looked at by your gynecologist, by your primary care doctor. And if they're uncomfortable, they can send you to us. We'll schedule an ultrasound for you and take a look at that. Questions about dense breasts, what alternative screening should be considered? I'm 58 and have always been told I have dense breasts and cancer might not be detected. So there are 4 categories of breast density. And if you're extremely dense, then you may qualify for extra screening. Sometimes that's with breast MRI. Sometimes that's with whole breast ultrasound. So if you have extremely dense breasts and you are postmenopausal, you're 58, I'm assuming you've stopped your periods, then you might be eligible to get some additional screening. Do you have any statistics for Asian women related to risk factors and such? Asian women actually tend to have a lower risk of developing breast cancer, especially depending on how long they've been in the U.S. and different theories have been brought up about change in diet when they come here. And once you move to the U.S., sometimes your diet changes more to our unhealthy Western diet. But usually Asian women have a little bit lower risk of cancer. I don't have data on like gene mutations in Asian women. Dr. Raja, I don't know anything to add to
I
that.
don't either, but Hispanic women and Asian women tend to have a lower risk of breast cancer. Caucasian women is at the top, and then you have Black women underneath that.
Yeah. I've heard of massages around the breast and lymph nodes. Skeptical. Does that help with prevention or risks in any way? So that doesn't really affect breast cancer risk one way or the other. Some women after breast cancer treatment will get edema in their breast skin or their breast, and massage of that tissue can help to drain that edema. There are centers that do lymphedema massage just in general, not because of breast cancer problems. They're massage therapists, not lymphedema therapists. And there's nothing wrong with that, but it doesn't really affect risk one way or the other. All right. Dr. Raj, you want
Okay, let's
to finish up?
go on. So the first thing I'm going to quickly talk about is breast self-examination, something simple that you can do at home. We like you to do it on a monthly basis. Now, we don't expect you to be a doctor. We don't expect you to know exactly what's going on. But if you get used to your breasts, get used to looking at them on a monthly basis, you'll notice if something starts changing, and then you can bring it up to your doctor. So you're going to look at yourself in the mirror, look for any changes, put your hands on your hips, and then above you'll raise your arms, look for any puckering of the skin. Does it pull in anywhere? Does it look a little bit abnormal? Is one shape looking very different to the other? You then want to kind of examine your entire breast. A good place is in the shower when it's nice and wet to help slide those fingers across. You want to go through the whole breast, going all the way up to that collarbone, up into the armpit. Lots of people forget that area, and you can do it whichever way you want, just with your fingertips. You can go around in a circle. You can go up and down. You can use a spiral, but you need to cover the whole breast. Once you cover it, just have a look at the nipples. Have you got any nipple discharge? We often say if you have bloody nipple discharge or a clear nipple discharge, particularly from one duct on one side, that is more concerning than if you have bilateral milky nipple discharge, which can be just normal. It's also helpful lying down and examining your breast. You can feel the under part of your breast much better. Now, you may have lumpy, bumpy breasts. That's very common, and you may not know exactly what you're feeling. But once your doctor has felt it, they say, yep, that feels normal. You can think, yeah, that's what this feels like. And then examine your breasts regularly. You'll get to know what they feel like and if you have any concerns. If you have any concerns, you can always see your doctor to just verify that. They'll probably want to do some imaging. Okay, so what are you looking for? You're looking for lumps. So if you feel a lump, usually it feels kind of hard, like a pebble just underneath in the breast. If you're not sure, it's okay. You can go to your doctor. If you notice swelling of the breast, so one side is swollen compared to the other, it could be a sign. If you have clear or bloody nipple discharge, particularly from one duct, but if you have it on both, you're concerned about it, come let us know. If you have a lump in the armpit, like she mentioned, it doesn't necessarily mean that it's cancer. Usually it's not. It may be a swollen lymph node. That's what we're looking for when we feel for lumps under the breast. Sometimes you can have a breast cancer in axillary tissue as well. But some people get abscesses in the breast from shaving usually. They can get infected cysts. They can also get that accessory breast tissue. You might notice dimpling in the skin. What we mean by that is you notice the shape looks a bit distorted. The skin is pulling in, especially when you move your arms up and down. It's just not moving right. That could be there's a sign of a cancer pulling that skin in. So that's another sign we look for. If you notice some thickening of the skin, we usually say it's like an orange peel. So if you look at an orange peel that is thick, it has that kind of pitting to it. If your skin is starting to do that, that is not normal. It could be a sign of infection. It could be something else, but you should follow up with a doctor with regards to that. If you notice your nipple, which was previously sitting out, is now starting to pull in, that can be a sign. Now, that can be a normal sign of aging. It can be a benign disease as well. But some cancers can sit behind the nipple and pull it in. So it's always worth seeing your doctor. If he says it's nothing to worry about, usually it's nothing to worry about. Often, if it is a cancer, if you try and gently push it out again, it's not going to push out. And then the last thing that we have on this slide is if you notice a color change of the breast. Now, usually it's uncommon for this to be a sign of breast cancer, but if you notice something, usually it's infection. But if you notice something that's abnormal, you can always come see a doctor with regards to that. Okay. So also, if you feel a new lump, or you feel an old lump that is increasing in size suddenly. So before it was like that, it was like a centimeter for years, and now suddenly it's 3 centimeters, it's 4 centimeters. That is concerning. Contact your doctor. There's a lot of reasons why you might get a lump, nipple discharge, changes in the skin. Most of them are not breast cancer. So first we want to make sure that it's not breast cancer, and then we can treat it as needed. Okay. Now, people often ask about breast pain. Breast pain is not usually a sign of breast cancer. So breast pain is very common, usually dietary or hormonal in nature. But there are lots of reasons you can get breast pain. The majority of them are not cancer. Usually breast pain causes cancer when it's a certain size. So usually we'll see other symptoms. Is that 100%? No. But the majority of times, if the mammogram's normal and your breast exam is normal, usually it's nothing to worry about. So let's talk about how we diagnose breast cancer. And the way we do that is with imaging. So there's three main imaging techniques that we use. Now, are there other things out there? Yes. Are they all equal? Not really. So let's talk about the ones that we use and kind of why we use them. So the gold standard, the one that we kind of really go to and really like, is mammograms. So mammograms are basically an X-ray of the breast. And you may say, well, mammograms have been around forever. How is that kind of improved in any way? And mammograms have improved over the last 10, 20 years. So initially they were just simple X-rays of the breast. As time has gone on, they became digital, where we could enhance them, we could look at them better. Now we have 3D mammograms, which do lots of different slices and give us a much better view of the breast. So mammograms have improved with time, much easier to see dense breasts than we did used to. Are they 100%? No. Is any imaging 100%? No. Typically, we start at age 40. The reason being, we talked about it, as you get older, the risk of breast cancer increases and also the density decreases. So it makes it easier to see through the breast. Now, in the past, they'll often say to you, you don't need to have mammograms after the age of 70. However, we discussed that as you get older, breast cancer increases. So it's worth continuing if you feel comfortable doing breast mammograms. So continue to a point where you feel you're not really going to do anything if it came back as positive. The exposure to radiation is what lots of people worry about, and this is really pretty minimal. So it's usually, we equate it to just walking around, the Earth for about 7 weeks, or even a transatlantic flight. So it's pretty minimal. So we don't usually worry about the amount of radiation that you're getting with that. It's usually uncomfortable to try and decrease that radiation and also to see smaller things. So sometimes they'll squish pretty hard. Nowadays, the techniques are much better, so they shouldn't be squishing as much as they used to. But sometimes if you've got very dense breasts, there's something they're trying to see, they may unfortunately squish you a little bit more than you want to be squished. So when we do screening mammograms, really for about every 1,000 mammograms we do, about 100 people are going to get called back. And the reasons for that is they see something they're not quite sure about, they want to take a second look at it. Now, majority of those times, you're not going to need to have anything else. They're going to say, yep, everything looks good. We just want to keep an eye on it. And that's fine. Now, there's two different types of mammograms that we do. Now, they're pretty similar in the way they do them, but there's some slight differences in them. So there's the screening mammogram, which is what every woman should be getting after the age of 40. So you'll go there, they'll take the x-rays, and within a week, usually you'll get a letter saying everything's great, nothing to worry about. Now, a diagnostic mammogram is slightly different. This is when you have a problem. So if you've noticed a lump, you've got nipple discharge, you have any issues at all, so you have a symptom, you should be getting a diagnostic mammogram. Do not wait for your screening. Tell the technician who is there. Don't think, oh, I'm just going to sneak this one in, because unfortunately, they'll usually want to rebook you to do another diagnostic. The reason being is they're going to focus in, they're going to do your usual screening, but they're also going to focus in on the problem that you complained about. So if you said, I felt a lump right here, they're going to make sure they look really closely in that area. And they may do ultrasounds, they may do additional views just to make sure. So make sure that you get a diagnostic mammogram if you have a symptom. Now, the radiologist is usually there, so you'll probably find that they will come and talk to you as well and say, yep, everything's great, don't worry about it, or we need to do more imaging, or they may say if they find something that they want to do a biopsy. But very important, if you have a symptom, get a diagnostic mammogram. So this is just a picture of a mammogram talking about the 2D, which is what we used to do, to the 3D, which really most people are doing now. We can definitely see much more indents breasts with a 3D mammogram. And this is what she talked about, the different types of mammograms. So we have people with fatty breasts, very easy to see stuff on. And then we have women with extremely dense breasts, which it can be very difficult to see things on. Now, those are the extremes, the fatty and the very dense. So about 10% of women are going to fall into that range. The rest of women, so 80% of women are going to fall into this other range. So a lot of women might have what we call heterogeneously dense breasts. A lot of women are going to fall into that category. We usually will say to you, if there is no additional imaging that we can do for you, to examine your breasts, and if you feel something, then to let us know. We can certainly kind of do some additional imaging on that. So breast ultrasound. Some women say to us, can we do a breast ultrasound instead of a mammogram? And the answer is no. And I always liken doing a mammogram is getting like a bird's eye view. So say if you're looking for something, you're a police officer and you're looking for a burglar who's just come out of a house. A mammogram is like being the cop in the sky. You've got that full kind of range of vision. You can see everything on the ground and you can focus in and see where that person is. An ultrasound is like having a policeman on the ground. He's doing the fine tooth comb. He can see that thing. So you'd have to tell him where to go. And that's what ultrasound is really good at. It's really good at looking at something if we know where we're looking. So the mammogram will tell us where to look. We look in that specific area. You will tell us you have a lump in a specific area. We can look at that specific area. You have nipple discharge. We know the area we need to focus in on. We can evaluate things a little bit better with the ultrasound, but it doesn't always give us a really good bird's eye view of everything that's going on. And we certainly can't compare one side to the other. There are other things we look for in mammograms that can't be seen in ultrasounds or MRIs. And these include little specks of white dots called calcifications that can be sign of early abnormal tissue or early breast cancer, or little distortions in the tissue that can be seen in mammograms as well. Now, we talked about MRIs, and MRIs can sometimes be thought of as like the gold standard. They do really well at picking things up, particularly in dense breasts, although sometimes they can have some issues with dense breasts too. The problem with MRIs is, and I'm going to come to that in a second. So there's a very specific set of people who may qualify for MRIs, and those are women with breast cancer genes. So if you have a BRCA1 or BRCA2, they're probably going to be screening you with an MRI. If you have a lifetime risk of greater than 20%, you're probably going to get an MRI. If you have extremely dense breasts, you may be eligible for an MRI. And that's where we talk about the risk factors. There's probably going to be some other risk factors that they'll need to look for in order to qualify you for that. Some new cancers we're going to do MRIs on just to make sure that we know that we've got everything. Some women with nipple discharge will do MRIs, and a certain disease that we call Paget's disease, which is of the nipple, those women often will get MRIs as well. Now, why don't we perform MRIs on everybody? If it's so good, why don't we do it on everyone? Now, the problem with MRIs is they're not the most pleasant to have done. And you thought that mammograms were bad. Well, MRIs are much worse. They involve you being there for about 30 minutes. You have to lie on your front. They're claustrophobic. They're very loud. They're extremely uncomfortable. They need to put a line into your arm. So you put a cannula in there and they put contrast in there. And we see how that contrast is excreted. Without the contrast, the MRI is not helpful. Some people are allergic to the contrast. In some women, they can have buildup of the contrast. If you have it every year, we don't know those long-term effects. And if you don't have a high risk of breast cancer, the risk does not really outweigh the benefit of doing it. It is difficult to interpret as well. Dr. Fernandez and I will tell you that we'll be happy to look at mammograms and ultrasounds, but MRIs take a lot of expertise to review and to know exactly what's going on. they can often be so sensitive that they show up a whole load of things, and then we have to test every single thing. So you end up with a lot of biopsies, and you end up finding that there was nothing wrong there, and you went through a whole lot of anxiety and a lot of biopsies and discomfort to be told that everything was normal. So unless you have a really good reason to have an MRI, we don't like to do them on everybody. All right. So we've done the imaging and we found something abnormal. So the first thing you can see is a mammogram with a mass in it. You can see that mass. With the ultrasound here, which is the second picture, you can see there's something abnormal in there. That's that black stuff there. And then the MRI on that side. This is what we call a subtracted view to make it easier. Both me and Dr. Fernandez can read those ones, make it really easy for us to look at. So we found something now. What do we do? And what we do is a biopsy. Now, breast surgeons can do biopsies, and often you'll get the radiologists do biopsies. And we often get our biopsies done at Seton Imaging. The reason being is they do a fantastic job, and sometimes they can give us 24 to 48 hours to, turnaround on those. So within 3 days, we'll usually get a result about what the biopsy shows, whether it's breast cancer or not. Now, there's a couple of ways in which we do the biopsies. It's a day procedure, so you'll come in on the day of the procedure. They'll numb the area up, they'll find it, they'll take the biopsy, you go home. They'll use some kind of imaging to do it. Now, it may be stereotactic. You can see that's how they do the stereotactic at the top. They use a mammogram machine, they'll numb the area, they'll use a needle to take that tissue out. Likewise, with the ultrasound, they'll use the ultrasound probe, they'll identify the area, they'll numb it up, they'll take it out with their little device, and same with the mammogram. Now, the MRI. The MRI is a little bit complicated. You can see the woman lying down there. They put a grid in, and often you'll be going in and out of the MRI machine because they can't do it in the machine because of the magnets. So it can be a little bit technically difficult. Now, whenever they've done the biopsy, they send all that to the pathologist who's going to look under the microscope and figure out what's going on. And once they've done the biopsy, they will put a tiny little marker in. It's, thinner than a little fingernail size. It is millimeters in size. It is very, very minute. You barely can see it with the naked eye. Is a tiny little clip that they're going to put in that spot. And they do that so that we know where the biopsy was. It's very important. It doesn't interfere with anything and you can't feel it. So often when you feel after you have a biopsy, you might feel some fullness and swelling in the area. Usually that's just from swelling and inflammation because of the biopsy and not from the biopsy clip. But the clip is very helpful to tell us where it is. They will always usually put one in. That is the kind of standard of care. All right. Sometimes we need to do a biopsy under general anesthesia, so we put you to sleep for that. That is often when they've tried to do a biopsy and they've not got what they need, or we need to remove the entire mass, or you have symptoms such as bloody nipple discharge and we can't find a cause, or we need to treat that cause at the same time. Then we will do what we call an excision biopsy. That's often done with a breast surgeon, but usually we have attempted a different type of biopsy before we get to that. Okay, so we've done the biopsy. The results have come back. If it comes back as benign, great news. Usually nothing more we need to do. Sometimes we'll need to keep an eye on you. It may come back as atypical. We already talked about what we do if it's atypical. We're going to follow you. Some people need surgery. Some people we just need to monitor in our high-risk clinic. But what happens if it comes back as cancer? So if it comes back as cancer, you'd be referred to someone like myself or Dr. Fernandez. You may also be referred to a breast oncologist, who is basically a cancer doctor that usually gives the medication treatment. So you may see either of us, but I always recommend that if you have breast cancer, you go to a specialized breast center. The reason being is that they will have a team of doctors dedicated to the breast itself, and usually what we call a multidisciplinary team. So they have a lot of doctors that just specialize in taking care of breast cancer. You want to make sure that any doctors you see are board certified or board eligible. That just means that we've been trained to a certain degree. those doctors, such as myself and Dr. Fernandez, will go over your mammogram. We'll let you know what we found. We'll let you know those biopsy results. And we'll kind of help you make a plan. So what we do is we'll tell you everything about that cancer, what type of cancer it is, because there are different types of breast cancer. And depending on where the breast cancer is, the size of the breast cancer, is it in the lymph nodes? What type of cancer is it? We'll talk to you about all those different things so that we can come together and make a plan together. Okay, we take into account all the things that may affect you too. So we have some patients. I have a patient who's over 100 years old. If you're that age, your ideas of what you might want to do may be very different from in your 30 years old. So we'll go over your different options and we'll come up with a plan that works best for you. Okay. I always say to patients, don't be scared to ask for a second opinion. If we say to you, we think the best thing to do is remove your breast and you just don't think that might be the right decision, feel free to ask someone else. Go and meet another breast surgeon. The more, more knowledge you have, the more comfort you have on doing, what you need to do. So do what you need to do to make that decision. Okay. You never upset anyone. You won't upset me or Dr. Fernandez if you say, look, I just want to check with someone else. Okay. And that's usually a good sign of a good doctor if they're happy for you to go and speak to other people. So who is part of the team? So when you meet a team and you have breast cancer, you're going to have the rock stars of the team, and those are your breast surgeons. So usually you'll have me and or Dr. Fernandez or a breast surgeon who will be helping liaise things, or the medical oncologist. And we will be the ones in charge of doing the surgery for you. Now, often on top of that, usually in a breast center, you will also have a medical oncologist and often a radiation oncologist. Now, you may not need either of those doctors, and usually the breast surgeon will talk to you about whether you need their input or not. And so the medical oncologists we have here are Dr. Palori and Dr. Rao. They specialize in breast cancer, and they usually will give treatments such as the medication, which is anti-estrogen therapy for women who have what we call hormone receptor positive cancers. And also they give chemotherapy. They also do some of the other treatments as well. And then radiation oncology, we have Dr. Hughes and Dr. Zuber, who are both, again, fantastic. And they give radiation treatment. And radiation is basically, I say it's a bit like an X-ray treatment to the breast and often the armpit area and the lymph nodes as well sometimes. And that just goes in and kind of scrubs everything down to make sure breast cancer doesn't come back in the breast or in the lymph nodes if that's what we're worried about. Now, not everybody needs all these treatments, and we will let you know whether you need it or not. And often, if you're not sure, we'll let you have a chat with them as well, and they can talk to you about what they would plan on doing so you have a better idea of what you would like to do. Often women will also see a plastic surgeon. If we need to do a mastectomy to remove the breast, then you may want to get reconstruction. Likewise, when we do a lumpectomy, if it's a big lumpectomy, you may notice a little defect in your breast. In the past, women used to just put up with it and think that was what, well, I've got breast cancer, I may be left with these deformed breasts. That is not something that you need to go through anymore. We will often be able to do something like a breast lift and match both of your breasts to each other. So don't expect to have breast deformity. If you're a good candidate, we will plug you in with our plastic surgeon who does a fantastic job to make sure that once you're done, you can be comfortable with that result. Okay. So that is all included with your insurance. So your insurance will cover the plastic surgery. Do not worry about that. Insurances have to do that. On top of that, there's a lot of other people who we work with to make sure that you get the best possible care for your breast cancer. Those include the radiologist who did the biopsy, the pathologists that look at the biopsy. There'll be nurse practitioners and physician assistants. There'll be social workers making sure that we can get everything to help you, that we can, any assistance treatments you might need. There's physical therapists. We talked about breast massage to kind of help if you've got some thickening of the breast or any edema, to make sure you don't have any difficulties in moving your arms. Some of you may have had family members who had breast cancer surgery in the past and they've had very swollen arms, or they've been really deformed, or they really suffered. And that is really a thing of the past now. We can often get women through this with minimal, side effects and things like that. And then we have genetic counselors that often you can speak to on the phone to talk about any abnormal results. So I'm just going to quickly summarize the treatment options. With surgery, we can do a lumpectomy where we just take the cancer out and a bit of healthy tissue, and we can leave the rest of the breast in place. So you do not need to lose your breast. Some women choose to have a mastectomy to remove the breast. Some women need to, unfortunately, have a mastectomy, but the majority of women should be suitable for a lumpectomy, and your surgeon will look over the imaging and tell you what they think you're suitable for, whether you're suitable for both or one or the other. And you can discuss that with them. We'll often sample lymph nodes as well, but that's not always necessary, to just see if you need any additional treatment. And then the other treatment options, which would be usually given by the radiation doctors or the medical oncologists, include chemotherapy, anti-estrogen, targeted therapy, immunotherapy, and then we talked about radiation. These are all to prevent breast cancer from coming back, prevent breast cancer from spreading, or to treat spread. So there's a whole host of things that we have to make sure that we can treat you to get rid of that breast cancer and also prevent it from coming back. Okay. Now we know 13% of women will be diagnosed with breast cancer in their lifetime. Over 90% of them are going to live more than 5 years, many of them over that. Okay. So, we want you to feel comfortable that this is a very treatable, very curable disease. My hope and Dr. Fernandez's hope is that once we do the treatment, you can go back to living the life that you were living before you got that diagnosis. Okay, so I'm going to open it up to some questions now and let Dr. Fernandez address any other questions you might have, or anything I may have missed.
So someone asks, I'm 42 years old and still breastfeeding. Can I have a mammogram? We usually recommend waiting until you're done breastfeeding to get a mammogram. The tissue density can be higher when you're breastfeeding. And remember, dense tissue can make it difficult to see things. So most radiologists say to wait at least 3 months after you finish breastfeeding. Now, that's assuming you don't feel anything or notice anything that's different. If you feel a lump, you need to get it addressed. But if your breasts look and feel normal as they have been, you should not get a mammogram during breastfeeding. Can a calcification dissolve on its own? I had a mammogram a few years ago where calcification was noted and the next year it was not. It can. Calcifications can, I don't know if dissolve is how it happens, but they can go away. They can also get more prominent and more evident. Not every calcification means breast cancer. There are calcifications that can happen just in damaged tissue. So if you're in a car accident and your seatbelt gives you a bruise on your breast, you may have calcifications in that area when you get your next mammogram. So yes, calcifications can go away. Does a breast cancer patient have to schedule appointments with all of these doctors separately before beginning treatment? So the answer to that is no. Like Dr. Raj said, most of the time people start seeing us first, seeing the surgeon first. And Dr. Rajarajan and I are the breast surgeons here at St. Agnes. And if the patient has the kind of cancer that they should be considered for starting with chemotherapy, then we will schedule the appointment with our medical oncologists. Every week, all of the breast specialists meet in a multidisciplinary breast tumor board. So we will present patients either after their surgery, if they had their surgery first, or if they're patients that need to get chemotherapy or some type of oncology treatment first, we'll present them. So we're looking at the slides of the pathology, we're looking at the mammograms, ultrasounds, MRI reports, and the whole team is there so that we can work out a plan. So no, if a woman has breast cancer, was just told she was diagnosed with breast cancer, If she calls our office, and the number is up there, 667-234-3434, and that's the number for both of our centers. So the Columbia and the Wilkins Avenue office has the same phone number. But if you call, you say you were diagnosed with breast cancer, then we'll take care of it. I tell people, this is all we do. You do not have to do a bunch of legwork before you see us. You give us a call, we'll take care of it. I also tell the referring physicians, the gynecologists and the primary care doctors, if you're unsure about a patient's breast exam, if you think you might feel a lump, if a patient, this is the other thing, we work with all radiology centers in the area. So Advanced Radiology, Hopkins Imaging, University of Maryland, Bay Radiology, we work with all of those centers. But sometimes you might get an outside mammogram and they call you back and they say, oh, and that you come back and you get another mammogram or ultrasound and they say, you need a biopsy. We can do it in 6 weeks. I can almost guarantee you that we can get that biopsy done in more like within 6 days, sometimes within 2 or 3 days. So we can take over from there. If the primary care calls us or the gynecologist calls us or the patient calls us and says, I need a biopsy and I'm afraid and they're telling me 6 weeks, but I want to get this done sooner, we can take over from there. Now, some insurances will require the patient to get a referral, but patients call us directly all the time. So I guess that's kind of the message we want to get to people. If you feel a lump, even let's say you had a mammogram 6 weeks ago and it was normal, but now you feel a lump. Well, mammograms aren't perfect. And if you're feeling something and you weren't feeling it 6 weeks ago, you need to get that looked at. What might happen? They might do another mammogram. Maybe they'll start with an ultrasound. At the very least, someone needs to examine your breasts. So mammograms aren't perfect. They're very important. We strongly encourage that you get a yearly screening mammogram. Very important, but they're not perfect. So if you actually feel something or notice something different in the shape or appearance of your breasts, don't ignore it. Breast cancer is a treatable disease, very often a curable disease, and we have a much better chance of curing it if we diagnose it sooner rather than later.